Now, let's say a few words about this breast cancer that everybody is so worried about. It's the word that has been used to terrorize millions of women away from beneficial hormone treatment for the last quarter of a century. It's also responsible for many broken marriages and relationships because sex became just too painful without estrogen to keep the vagina healthy and happy. And sex is not a bad glue for many relationships. Hello, welcome back to Gyno Info. Or if this is your first time, just welcome. I'm so glad you discovered us. In this podcast, we discuss common gynecological problems in a frank and open way that normal everyday women can understand without a medical dictionary. Today, we're going to talk about the changes in your hormones at midlife, the so-called perimenopause. Menopause is the time after your ovaries permanently stop working. They stop making eggs, they stop making hormones, and so your periods stop. It is the pause, the stop of your menses, of your menstrual periods. Most women go through menopause somewhere between 45 and 56, but 5% before 45, and about 1 in 100 women go before 40 years of age through menopause, in their 30s. The average age is about 51 to 52 years old. Menopause then lasts for the rest of your life. You're in the menopause or the postmenopause until you die. Some people call that also the climacteric. The perimenopause is what we call the years that lead up to the menopause. Some signs and symptoms of perimenopause, however, start way before midlife, already in your 30s, many years before the actual menopause, the pause of your menses. Symptoms could be killer PMS, worse than when you were a teenager, screwy periods. Sometimes they come too close together, sometimes too far apart. Sometimes they're too hard. Sometimes you bleed hardly at all. And sometimes they're completely normal, like you've had them for the last 25 years. They just get unpredictable. You can also get headaches and migraines, but mostly just before your period. You can have breast pain, and that not just before your period, but all month long. You can't even touch your breasts anymore. They're so sensitive. And then they go back to normal. This comes and goes, these perimenopausal symptoms. You will probably be experiencing sleepless nights and that famous brain fog. You can't concentrate. You forget what you were talking about. You forget names, brain fog. And yes, it's the hormones produced and now no longer produced reliably by your ovaries that are causing all this havoc you may be experiencing in your life. Even though you still have periods and think you're way too young to be anywhere near menopause. But that's what it is, the perimenopause. Now let's do a little basic gynecology. What hormones are produced in the ovaries and what do they do? And note here that I'm talking about human hormones produced by human ovaries because you're not a soybean, nor are you a red clover or a yam or a horse. We used to give horse hormones in the olden days to women because the natural hormones weren't available. The ovaries produce 3 types of sex hormones, as opposed to thyroid hormones produced in the thyroid and insulin produced by the pancreas. Those are the sex hormones produced by the ovaries. Hormones are to be understood kind of like memos or orders. They're produced in one part of the body and tell another part of the body what it should do now. Without hormones, our bodies can't function and we die. I get sometimes women who come to the office and say, "Oh, I don't want to take any hormones. I'm scared of hormones. Hormones are terrible." And I say, without hormones, you wouldn't have been able to arrive here in my office. Hormones are necessary for life. So these three sex hormones that the ovaries make are estrogens, and the main one and the most powerful one is called estradiol. And then there's progesterone, which deals with periods and pregnancies. And then there are the androgens, male hormones, and that's mainly testosterone, the most potent of these male hormones that are made by the ovaries. It may surprise you to hear that women make testosterone in their ovaries, but they do, just a lot less than men make in their testicles. Here's why the ovarian hormones are so incredibly important. They affect basically every part of your body and even your mind. They, especially estrogen as a rule, have positive effects in your body. No longer making these hormones in the ovaries, especially no longer making estrogen reliably when your periods become irregular during perimenopause, then menopause, has very negative consequences. You may be having hot flashes and cold flashes and palpitations, your heart beating fast, dry vagina and pain with sex, and bladder problems, inflammation causing muscle aches and joint pains, stiffness, bone loss and osteoporosis, brain fog, forgetting names or losing your train of thought, having problems concentrating, problems falling asleep, problems staying asleep, waking up really early in the morning and not being able to go back to sleep, losing patience with your teenagers at home and the men at your work telling you stuff you've known forever. You used to let it slide, now you blow up. These hormones can even change how you'll find your park in the parking lot after work. Do you do it by row numbers or do it by landmarks? That's influenced by your hormones. And definitely how quickly you make up your mind and can make decisions is also influenced by your hormones. By taking the right hormones in the right amount and at the right time, you can change and prevent these negative effects. But again, because we're humans and not soybeans, yams, or horses, any kind of supplementing or replacing therapy should be done with natural, bioidentical human ovarian hormones. Now, here's what the second hormone, progesterone, does. Estrogen makes the lining of the uterus grow. Progesterone then organizes how this lining is shed every month, or how it feeds in early pregnancy until the placenta takes over. Progesterone is produced in the second half of the menstrual cycle after the egg is released after ovulation. When progesterone stops being made, menstrual bleeding, the period starts. If irregular periods or just shorter cycles are your main gripe, then overriding your unreliable flaky ovaries with an ultra-low dose birth control pill that will give you predictable periods every 28 days is a very reasonable and effective option, provided you have no contraindications such as smoking or problems with blood clots. Low-dose birth control pills in that age group are also a first-line choice for PMS, and they provide birth control, which is still an issue at this phase in your life. You're still fertile. You can get pregnant. It's just not as likely. You're not as fertile as you used to be, but you can get caught. If your periods are still regular, but you have killer PMS, so-called perimenopausal PMS, because your ovaries no longer produce enough estrogen towards the end of your monthly cycle, they get kind of lazy and kind of quit before the end, then supplementing with natural estrogen is your ticket to feeling like yourself again. You will only need to supplement with estrogen before your periods when your estrogen levels are low. As soon as the bleeding starts, you can stop it. It's supplementing, just helping it along a little bit. It's not full-fledged replacing. But if your periods have pretty much stopped or you only have a few of them a year, it may actually be time for full-fledged menopausal hormone therapy with both natural human estrogen and natural human progesterone. Because the lining of the uterus is designed to be shed every month, when you take estrogen for treatment of menopausal symptoms, you also need to take progesterone. It keeps the lining from getting too thick, which can cause problems such as severe bleeding, and eventually, after many years, you can even have cancer. Estrogen you use continuously every day for 365 days a year. Estrogen you use continuously every day for 365 days a year. Progesterone you add either for the 14 days in the second half of the month, like the ovaries used to do it, and then you have a light period, a so-called withdrawal bleed, when the progesterone is stopped. But because most women do not really love having periods, certainly not past age 50, you can also take progesterone continuously, counteracting the effect of estrogen on the uterine lining with progesterone as you go along. Then the lining of the uterus doesn't grow at all, and then there's nothing to shed. And if there's nothing to shed, there's no bleeding. Keeping the lining of the uterus from getting too thick and causing bleeding problems is really the only reason why you should have to take progesterone in menopause. If you don't have a uterus, if you had a hysterectomy, your uterus was surgically removed, you do not need to take progesterone at all. Those bioidentical natural hormones are, for the great majority of women, the most effective and also the safest treatment option for perimenopausal and menopausal symptom relief. They pose minimal risks for healthy women without contraindications, including no extra risk for breast cancer. I'll get into the breast cancer stuff later in this podcast. All respected guidelines on menopausal health in the world say, including the Swiss OBGYN, which I helped write, say that estrogen is the safest and most effective method to treat these menopausal and perimenopausal symptoms. But no hormones can make up for a lousy lifestyle. You have to eat healthy and make sure you get enough protein and calcium for your bones and for your muscles. You have to stay fit and strong. Being strong is much more important than being thin. You should stop smoking or cut back drastically how many cigarettes you smoke, and vaping is not much better. You should cut back on alcohol, take care of your stress and mental health. Learn that you don't always have to be perfect, that good enough really is good enough most of the time. And you have to learn to pay attention to what really matters, and you have to say no sometimes. You don't have to do everything that somebody wants to do from you. You decide whether you're willing and able and happy to do something or not. There are women who have absolute contraindications, and they cannot take natural ovarian hormones for medical reasons, such as a blood clotting disorder or a cancer that likes to eat estrogen, and when you feed it estrogen, it will grow faster. For them, there are now safe and effective pharmacological options. These prescription medications, however, will, as a rule, only treat one symptom per drug. One medication works for hot flashes. One works for bone loss and osteoporosis. One for high cholesterol and heart disease. And none of them really work for dry vagina. But estrogen is good for all of them. So now let's say a few words about this breast cancer that everybody is so worried about. It's the word that has been used to terrorize millions of women away from beneficial hormone treatment for the last quarter of a century. It caused many millions of women to now have osteoporosis. It's also responsible for many broken marriages and relationships because sex became just too painful without estrogen to keep the vagina healthy and happy. And sex is not a bad glue for many relationships. Explaining the medical science on menopausal hormone therapy and its relation or not to breast cancer will take a whole episode and more. And I promise I'll be doing it one of these days. But for now, just let me say this. Women and many of their doctors have been unbelievably misinformed by a study that came out about 25 years ago, the now infamous Women's Health Initiative. This study gave one particular type of horse estrogen and one particular type of artificial progestin to older, mostly overweight women in their 60s and 70s who didn't have hot flashes. It was actually designed to show benefits on the heart, which it did. The result of these studies were then applied to all women and all types of estrogen and progesterone. Specifically, it was applied to healthy, young, perimenopausal and menopausal women with hot flashes taking natural bioidentical hormones. So this makes, of course, no sense whatsoever, and certainly never did to me. I went with the science, and I've been taking natural human estrogen for the last quarter of a century, and I don't have any intention to stop. It may actually explain why I look a little bit younger than my 74 years. And it's also the explanation why I dropped out of the North American Menopause Society in protest when they were being hysterical and ignoring all science about 25 years ago. And then I joined the International Menopause Society, which did look at science and did not come out with crazy recommendations that people should take estrogen in the lowest possible dose for the shortest possible time because it was really horrible and you should only take it if you had killer hot flashes that you just couldn't tolerate. But a few years later, the North American Menopause Society joined the rest of the world and the guidelines of the International Menopause Society. And they did no longer talk like some hairdressers that are still telling women that estrogen is the worst in the world. Natural human estrogens actually do not cause breast cancer, according to the latest medical science. Nor does natural human estrogen combined with natural human progesterone cause breast cancer. In fact, estrogen taken alone without progesterone actually lowers the risk of breast cancer. The culprit causing the breast cancer in that old study from 25 years ago that made everybody hysterical was apparently that artificial progestin called medroxyprogesterone acetate, Provera, that was the drug used in that particular study. This drug, this artificial progestin, Provera, has not been used in Europe for decades, and it has been taken off the market in most, if not all, European countries. It's still available in the US for some reason. I stopped prescribing this drug in the 90s as soon as natural human progesterone became available. It never made sense to me to give something artificial when the natural human hormone was actually available. Why would you give anything else than the thing that's missing that the ovaries are no longer making? Of course, if you do have a breast cancer that likes to eat estrogen, and not all of them do, and you then feed it estrogen, of course it will grow faster. So those women should not take estrogen. That is why you should regularly check your breasts, you should check for lumps, feel, and you should also have regular well woman visits. And after about 50, periodic mammograms. Now, the real risk factors for breast cancers are drinking more than 2 units of alcohol a day, being more than 20 kilos, that's about 40 pounds overweight, and walking less than 4 hours a week, being really inactive. Each of these risk factors almost doubles the baseline risk of breast cancer. But smoking is the absolute biggest risk factor for all of them. It causes twice as many as the first three factors combined. Smoking causes twice as many breast cancers as drinking too much, weighing too much, and walking too little. So the risks of taking natural human estrogen and progesterone are minimal compared to the benefits for most women. Serious complications are extremely rare. Not even 1 in 1,000 women experience a serious complication per year. Which hormones you take also matters. Natural versus artificial, estrogen alone versus estrogen plus progesterone, and then what progesterone. And how you take the hormones matters. There is a mildly increased risk of gallstones, blood clots, and strokes, but that's only for pills, not with gels and patches. Giving hormones directly through the skin, as in a gel or a patch, as opposed to taking a pill, is called transdermal. And it's actually how the ovaries do it. The ovaries give hormones directly into the blood. They don't send it first to the stomach and the intestines and then the liver and then the blood. They give it directly into the blood. And if you use a gel or a spray or a patch, it also goes directly into the blood. So this is not only a bioidentical hormone like estradiol, but you also give it in the bioidentical manner. So there are only two absolute contraindications for menopausal hormone therapy. One is a genetic blood clotting disorder, and the other is a cancer that likes to eat estrogen: breast cancer, endometrial cancer, certain ovarian cancers. And remember, there are many more contraindications for birth control pills than for menopausal hormone therapy. There's smoking, certain types of migraines, and of course, blood clots and estrogen-loving cancers also. Birth control pills are higher doses of synthetic hormones given to override still functioning ovaries. Menopausal hormone therapy consists of low doses of natural hormones that are no longer produced by the ovaries. That's why there are different risks. It's comparing apples and oranges. Both are fruit, but they're not the same. So this brings me to the end of this podcast, and I want you to remember three things from today. First, midlife hormonal changes are absolutely normal. Every woman has them. Even men have them, actually, but you probably figured that one out by yourself. Second, some of the symptoms may start way before midlife, already in your 30s, like killer PMS, screwy periods, headaches and migraines, breast pain, sleepless nights, brain fog, muscle aches, and joint pains, all those symptoms we've discussed. And third, I want you to remember that hormonal symptoms can be treated and can be dealt with, but differently for every woman. One size fits all doesn't work for pantyhose, and certainly not in women's healthcare. And because this episode is just a little bit longer than usual, these hormones are so important and interesting. So I talked a lot. So instead of my life tip for the week, I'll give you my perimenopause tip for today. First, take charge and stay in control of what's happening with your hormones. Notice, think, and talk about it. There's nothing to be ashamed of. Talk about what is going on, get informed, and do something about it. Talk to your doctor, and if she is not listening to you, find a doctor who is more interested in menopause and hormones than delivering babies and doing hysterectomy. You also need to find a doctor who is well informed about menopause and hormones. A lot of the doctors who trained in the last 25 years after that horrible Women's Health Initiative study are way undertrained. But there are very good courses now specifically on menopause, and it's actually certification in menopausal medicine that they can take. And it's changing. The younger doctors now are getting to learn more about menopause again. I really hope you enjoyed today's podcast, learned a lot. And of course, I hope that you will tell all your friends about it, especially those who are you think they're having some hormone problems. And then when you listen or look at this podcast on YouTube, please give us a lot of likes and subscribes because it will make it easier for other people to hear about it. Thank you. Goodbye. Until next time, thank you for listening. And remember that you and your health are super important and deserve your full attention. Don't ever put off contacting your doctor because you're scared or embarrassed when something feels wrong about your body. Doctors are here to help you and not to judge you. And also, regular well woman visits are always a good idea that you should make time for. You deserve it, and you owe it to yourself, and you owe it to your body and your health. This podcast is part of Pride House Media, hosted by me, Dr. Burki, produced and edited by Josh Rosenzweig. Original music composed by Nell Balaban. If you enjoyed this episode, please subscribe wherever you listen to podcasts. And while you're there, leave us a rating and a review. It really helps others discover the show. Stay connected and join the conversation by following me on Instagram and Facebook at Gyno Info and on LinkedIn at Gyno Info Podcast. Remember, any questions that I answer or information that I give you on this podcast are to be understood as information only, not treatment of your medical problems. While I'm a very knowledgeable gynecologist, I'm not your gynecologist who has talked to you and examined you personally and is therefore actually able to treat you. So please consult your own healthcare professional with any medical questions or concerns.